If you still think 140/90 is the magic line for hypertension, this video will update your mental model. The 2017 ACC/AHA guideline redefined blood pressure categories, set lower treatment targets for many people, and emphasized accuracy above everything. I'll walk you through how to diagnose, when to treat, what to prescribe, and how to follow up, plus a few memory hooks you can use on the wards and in clinic. First, the new categories. Think of the latter as normal elevated, stage 1, stage 2. Normal is less than 120 over less than 80. Elevated is 120 to 129 systolic, with a diastolic still under 80. Stage 1 is 130 to 139 systolic or 80 to 89 diastolic. Stage 2 is 140 or higher systolic or 90 or higher diastolic. Notice that stage 1 now begins at 130 80ths, not 140 90ths. That changes based on risk data. Small BP differences add up to meaningful changes in cardiovascular events. Before you label anyone, measure correctly. Use the 4 C's. Calm, cuff, chair, check. Calm, let the patient rest. No caffeine or nicotine just before the reading, don't talk. Cuff, pick the right size and put the arm at heart level. Chair, feet on the floor, back supported, no crossed legs. Check, take at least 2 readings, average them, and do this on more than 1 visit when possible. Then confirm the diagnosis outside the office with home blood pressure monitoring or 24-hour ambulatory monitoring. Quick equivalents to remember: home BP around 135 85ths, daytime ambulatory around 130 80ths, nighttime around 110 65ths, and 24-hour average around 125 75ths line up with the office thresholds. When do you start medication? Use this fork in the road: stage 1 with low risk versus stage 1 with high risk. If someone has stage 1 hypertension and a 10-year ASCVD risk under 10%, start with lifestyle therapy and recheck in 3 to 6 months. If they have stage 1 and a risk 10% or higher, or they already have clinical cardiovascular disease, diabetes, chronic kidney disease, or they're older with higher baseline risk, start medication plus lifestyle and follow up in a month. If they're stage 2, start 2 first-line drugs from different classes right out of the gate and see them in a month. Here's a quick hook: 1 if high risk, 2 for stage 2. What target are you aiming for? For most adults with hypertension, especially those with cardiovascular disease or a 10-year risk of 10% or more, the goal is under 130 over 80. For lower risk adults without other issues, less than 130 80ths is reasonable if they tolerate it. In older ambulatory adults, target systolic under 130 when it can be done safely. Personalize for frailty and symptoms like orthostasis. Bottom line, 130 80ths is the default, but use clinical judgment. Lifestyle remains the foundation. Coach weight loss if needed. A DASH-style eating pattern, sodium reduction, potassium-rich foods when safe, regular physical activity, and moderation of alcohol. These changes can drop blood pressure as much as, or more than, a single medication, and they make meds work better. For medications you have 4 first-line classes: thiazide-type diuretics, ACE inhibitors, ARBs, and calcium channel blockers. Pick any of these based on the patient, then combine as needed. If the patient is stage 2 or more than 20/10 above target, start 2 agents, either as separate pills or a single fixed-dose combination to simplify adherence. Avoid dual renin-angiotensin blockade. Don't combine an ACE inhibitor with an ARB. A few population-specific tips. For most Black adults without heart failure or chronic kidney disease, start with a thiazide or a calcium channel blocker. In CKD with albuminuria, favor an ACE inhibitor or ARB and monitor creatinine and potassium. In stable ischemic heart disease, beta blockers and ACE inhibitors or ARBs anchor your regimen, with thiazides or calcium channel blockers added as needed. In heart failure with reduced ejection fraction, treat to under 130 80ths using guideline-directed heart failure therapies that also lower blood pressure. Follow-up cadence matters. After you start or change medication, see the patient monthly until control is achieved, then space it out. Encourage home BP logs and use them to titrate therapy. For stage 1 low-risk patients managed with lifestyle alone, reassess in 3 to 6 months. Let's touch resistant hypertension. Define it as blood pressure above goal on 3 different medications at maximally tolerated doses, ideally including a diuretic, or controlled blood pressure that requires 4 or more meds. When you see it, verify adherence and measurement technique, stop or reduce substances that raise BP, screen for secondary causes like primary aldosteronism, renal disease, obstructive sleep apnea, or medication effects like NSAIDs and steroids. If the basics are optimized, add a mineral or corticoid receptor antagonist, such as spironolactone or eplerenone. These often make the difference. Finally, urgent versus emergency. A hypertensive emergency means severe blood pressure with acute target organ damage. Think encephalopathy, stroke, myocardial ischemia, pulmonary edema, aortic dissection, or acute kidney injury. Those patients need ICU-level care and titratable IV therapy, with an initial goal of reducing mean arterial pressure by roughly 25% in the first hour, then to about 160 over 100-110 over the next 2 to 6 hours, and then cautiously toward normal. A hypertensive urgency is severe blood pressure without acute organ injury. Adjust oral therapy and arrange close follow-up rather than rapid IV drops. Here's your rapid-fire recap. Categories: normal, elevated, stage 1, stage 2, with stage 1 starting at 130/80ths. Measure right and confirm out of office. Treat stage 1 if risk is 10% or higher, otherwise lifestyle first. Start 2 meds for stage 2 or when you're more than 20/10ths above goal. Aim for less than 130/80ths in most, tailored to tolerance. Choose from thiazide-type diuretics, ACE inhibitors, ARBs, and calcium channel blockers. Avoid ACE plus ARB. In Black adults without HF or CKD, start with a thiazide or CCB. In CKD with albuminuria, favor ACE or ARB. Follow up monthly until controlled, and think spironolactone when BP resists. Emergencies get careful IV reduction, urgencies get thoughtful outpatient adjustments. If you keep those beats in your head, measure right, confirm outside the office, 1 if high risk, 2 for stage 2, and under 130/80ths for most, you'll practice squarely in line with the guideline and, more importantly, you'll prevent strokes, heart attacks, and kidney failure.